I thought it might be applicable because a lot of times comments start coming up on this. And when I get done with this, as we start transitioning into the case, I would appreciate some of your feedback if you think this is something that we should consider including into our regular schedule talks. So I don't have any financial disclosures, no conflict of interest for this talk. At the end of this presentation, I want to talk about some common reasons why we might want to taper opioids, begin effectively communicating how we're going to do a plan with our patients, and learn some basic opioid tapering concepts. A lot of this really comes from the 2016 CDC guidelines, on which we're all given kind of that warning, hey, too much opioids is a particular problem, and we need to get our patients off and to wean down. I felt back when this was first published that more attention could have or should have been applied to how best to safely taper this down. In the 2022 revision of the CDC guideline, we begin seeing a little bit more science or evidence-based approach by the CDC on how to do that. So we're going to kind of cover some of those things here in this talk. I want to begin this with a case as per the Echo style, and we're going to do the case of Mr. T. This is not the Mr. T. And I looked it up, and Mr. T's that I grew up and knew is a little older than 54. If you're too young and you don't remember Mr. T, check out Rocky 3 or the A-Team. Great character. So he's a 54-year-old male with a history of chronic low back pain who's new to your practice. He's on hydrocodone, acetaminophen 10-325 4 times a day, plus morphine sustained release 3 times a day. And that gives us a morphine milligram equivalent of 150. He reports significant constipation, has a history of obstructive sleep apnea, uses CPAP infrequently. Mr. T is not on any adjunctive treatments. His PDMP is appropriate, and his UDS is paused for oxycodone and opioids only. Negative for 6-monoacetaminophen. He reports no other substance use. So to us is, when would you consider tapering him, and how might you communicate this plan with the patient? So again, feel free to type in on the chat or unmute yourself and provide an answer. The more you guys talk, the less you have to hear me talk.
I think I'd see how he's doing with his pain, given that he's reporting side effects from opioids, and that, he has obstructive sleep apnea. He has some risks. We'd want to kind of maybe see how he does and talk about if he's willing to kind of taper off.
Thank you so much, Mike. I appreciate that. For the healthcare providers, that Mike is a pharmacist and is very good at what he does. And Ernie Dole was our pain pharmacist who recently retired, and is a huge loss for us. We miss Ernie. All right, so
love an answer to this, because all of my patients come in, and of course their pain is a 20 out of 10, and they cannot taper their medication down because they need it.
yeah, and then they don't function well without it and all of that. And so and Sarah, I think your experience is very typical. And so what do we do, with that? And do we want to kind of and just giving away that some of that stuff is where we're going to go in the talk on how to do that. And it can be a very difficult conversation. One of the things that I do is I'm coming in, and this is, I'm establishing this patient new with me, and I'm disinclined to make any major changes on his medication, because what I'm trying, my initial goal is to really grow and develop that doctor-patient relationship, because that relationship is going to be critical for me trying to titrate or to cut down, or as we go forward, and me not touching his opioids on the first one or on that or putting some other plans together, is more likely he's going to come back and as opposed to start doctor shopping until he finds somebody who can just write it too. Thank you, Jeanette. And so as far as our discontinuation goes, when to do it, and I think we're asking some of those questions like what Mike said is, you know, how comfortable is he with his pain? Is he doing safe things? We have history of overdose, all those things. I think if the patient's showing signs of aberrant behavior, like they're diverting, they're refusing monitoring, then we kind of need to move this kind of aggressively. At the same time, I think it's important to also recognize that there are real risks in titrating somebody down too fast. We specifically in the literature, we have increased mental health outbreaks that happen, which are essentially defined as an admission to a psych hospital or a suicide completion. We've had well, not in this peer review literature, but in the lay press has identified cases of physicians being murdered because they wouldn't write pills, plus pain that's out of control for the patient. And so cutting somebody down is also not always a safe thing to do. As far as how much and how far do we cut down, I think it's not always black and white. I think we quote the 100 morphine milligram equivalents. Other references will say 80. We also recognize that high dose being 50 from the CDC, and where I think it's important to recognize where some of that data is coming from, and that a lot of that comes from data and about 10 years old now, looking at fatality data and going back and looking at PMPs. And also, I think recognizing that if we have this patient who's on 150 milligrams or MMEs and has been stable there for years, cutting him while the opioids may not be in the long term helping his pain, but transitioning him off, you know, how pressing is that? Certainly, I don't want to be generating the argument for we have to keep him on there. I'm just simply saying is, I get some providers that just want to rapidly take everybody off, and that's not safe to do either. So it's kind of like navigating a battleship through the Panama Canal, slow and steady here. I think ultimately this comes from how do the benefits outweigh the risks, and having that discussion with the patient. And I think also framing the situation where we're not defining the patient as bad. It's if the patient's unable or cannot get off the meds, that they're bad, they've done something wrong, or they should feel guilty or something like that. We shouldn't be thinking, do I need to trust the patient? Again, that as a special shout out again to Jeanette, is that doctor-patient relationship is really important, and develop it. Are things that we might not be necessarily doing this also for the right reasons. I spoke a little bit out of order, but here's the study identifying major health outcomes from JAMA in a cohort over a 10-year period of time, looking at over 100,000 people with statistically worse outcomes, rapidly tapering for increased overdose risk and mental health crises. So I think the goals of tapering is first and foremost, we got to get the patient on board. We're not going to be successful if we don't. 10 years ago, when heroin was really on the rise, you know, I would be talking to you and saying, hey, if patients aren't getting their opioid, that's the gateway to transition to somebody on the street. Fast forwarding in today, while I don't have the evidence, the counterfeit fentanyl tablets that are ubiquitous in our environment is an alternative if this doesn't go well for the patient, and we want to try to avoid the street sales too. So I think we want to first of all maximize our non-opioid analgesics for a patient, and that really becomes all-encompassing, because just thinking about if I was in chronic pain, I struggled getting out of bed to the couch after I went to the bathroom and my day was going to consist of binge watching Netflix all day, that just sounds pretty depressing way to go, or to be living my life. And so there's oftentimes a depression component to this. And starting to recognize the mental health needs, begin addressing the anxiety that they may be experiencing. And I think Sarah, in her brief introduction on how patients are coming, I don't know, I just felt like she's already feeling or just the anxiety being reflected back to her from the patient was palpable as she described that. And so starting to treat and dealing with some of the anxieties, whether it's involving a therapist, involving medication. I mean, again, that's a discussion between you and the patient and most appropriate. I prefer per counseling therapy is just my bias and trying to avoid drugs, but that's me, and other people just want the meds and don't want somebody like Evelyn yet. Also, the taper should go slow. I think of between visits, if you're doing by 10-20% over a course of a month, I think that's at a reasonable pace. Some months are going to be slower than others. Some we may be able to go faster. I also find that giving the patient control and having the patient more say really helps both develop that trust, but then the buy-in that we're doing the right things. So for some of us who are aging on here and who have those aches and pains from our joints just a little bit more every day, I think we can all tell you that I have good days, and most of my days are good days, but I have that 1 or 2 bad days a month where I really need the meds. And if I'm having a good day and a break, that's a day, hey, we can skip a dose. We can kind of cut down on some of it and utilize some of those good days to already use the momentum that the patient's giving us there. I think as far as, preventing overdose, we've talked a lot about that, here. But we want to make sure that the patient isn't having significant bouts of discomfort or withdrawal symptoms. If the patients have an opioid withdrawal, we're titrating way too fast. If they're having an increase in discomfort, again, we should have a talk with the patient about what they're going to do up front. I know this also gets to be a lot that we're going to talk with the patient about, especially, and I think, part of it is that's why that first visit, we allow more time so that we get that good, long, thorough history physical, and we're allowed some more time to talk about it. But if you take the time and you do the work up front, and especially you have that patient-client relationship, that it's going to save a whole lot of work down the road. Again, communication is key here. Shared decision-making with the patient. I think I've given some examples of that. But goal setting, and this is really important. I think we've moved away in medicine from 0 to 10 pain score, and how do we get you pain? How do we try to minimize your pain? Because frankly, getting some people to 0 involve general anesthesia for their pain, and that's not a good outcome. But what we want to do is, what are your goals? Most of mine, when I'm dealing with this, it's as we get old. For those of you who are young, stay young, don't get older. It's just so much better. So a lot of this is that they're at that age where they just want to be grandma or grandpa, and they want to play with the grandkids. And so now that's the goal that and then they'll tell you this, like, I don't care if I'm sore for 3-4 days and I can't get out of bed after the grandkids come, I'm going to play with them. And so then it's my approach or my job. So what is hurting? What is inhibiting you from doing that? What are the services that I need to bring on board to help meet those goals? So do we need physical therapy, occupational therapy, is what people think of first. But bringing on chiropractics, I don't have a problem with that, doing some of the bony manipulation. For back pain, the evidence is really, really strong supporting acupuncture. And have we offered that? As far as people who struggle moving, encourage hydrotherapy, aka a hot tub and a pool. And because Medicare and Medicaid don't pay for you to install a hot tub in your house, hey, it's a gym membership. And what do people do? You know, and it's okay to go to the gym and just hang out in the whirlpool. And hopefully at some point they start, you know, checking out the treadmill or the exercise bike and do some other physical activities, and all just about and walking in and out of the gym, all just other things that we can do to try to support them. Hector points out medical hypnosis. I'm in agreement here too. And again, I'm just putting out options here, and appreciate Hector's involvement, is that no one person is the same. And as you start putting these goals together, the patient very rapidly recognizes that you're there to help them. You've got resources. Hey, some of this stuff might not work, but some of it may. And we're just going to try and figure out what works for them. And you're going to support them through the process. Also very motivating. Having the pain or having a nurse call and check in on a patient. Patients love this. And just to see, hey, how are you doing? That, you know, they're just not a number. Usually goes a long ways. And if they say, hey, doc, I'm miserable, I can't possibly do this, you know, okay, fine. We're at least going to put a pause and not taper you down anymore. I hear that. And let's work on some of these other, let's give some time to figure some other strategies out, and we'll start breaking out the lidoderm patches and stuff. As far as the order on what to taper, I don't think it really matters too much from a medical standpoint. I think what's most important is giving the patient choice or control on this. It's been quite a while since I've seen somebody on crisaprotol or the drug Soma. It's a drug that I think should just be taken off the market. But trying to decrease our long-acting opioids. Again, the majority of the studies that have been done looking at chronic pain, especially that we start getting out a month or more, is that patients who are on long-term sustained release opioids generally don't have a much more improvement in their pain as if we didn't have them. But to Sarah's point, we tend not to be that physician or prescriber who starts people on those high doses. We inherit these patients from other providers in 2023 and where they're at. So that's more of the paradigm that I'm taking. If they're on a benzodiazepine, sure, we want to try to get them off. And we can have another echo talk on titrating down on benzos too, but that's just really hard to do. Very low and very slow to be able to do. And then, you know, short acting opioids maybe is kind of a last to go, or a benzo is the last one to go. And again, being flexible with the patient's schedule, I think, is helpful. Now, really, I love, but I hate slides like this because there's no way y'all can memorize all of this. I'll send a copy of this to Rachel and who can disseminate it, because I think these are the slides that provide a ton of information, and we can kind of adapt it to our own individual patient. You know, somebody who's truly diverting, if we taper them, or no taper is needed, but I kind of disagree with that a little bit, because most people who are diverting are also using some substance. And so we need to get them down, generally want to get them down and off fairly rapidly, because it's contributing to illegal activities and can put us at risk. But again, having a talk with a patient, I think most of this time when they're diverting, they actually have number one, which is substance use disorder. And I think we on this echo do a pretty good job of describing how we want to handle substance use disorder and what ways we can do it in diversion. So again, going back to our case, we talked to Mr. T about our concerns with his dosing regimen and his all of that. And we elicit from Mr. T what his goals are, and he shares that his concern, despite being on the medication, he continues to be in pain, is not able to meet his own functional goals. And we discuss that there's a variety of other evidence-based approaches with him, and he is interested in exploring opportunities to come down, because most of our patients don't want to be on it. And so things to consider, what adjuncts might we want to use and how might we taper the opioid analgesics at this time? And I think I may be going a little bit long and redoing this. So again, we're going to go slow. You know, a 10% reduction of the original dose, I think, is really well. We can involve other people. While it sounds a little bit goofy to involve a therapist in with him, asking, if he's open to it, to explore, does he have depression? Does he have anxiety? Does he have other mental health? If I'm not comfortable dealing with it alone, I think our therapists are wonderful and great support. Encouraging our patients and letting them know that we're going to stick with them. And I usually, by the time we inherit these patients, they've experienced a lot of things that haven't worked for them, and maybe hesitant to try some things that they probably didn't give a fair try to. So we're all going to kind of work around and into that. I think it's also important, as we're going through on some of these wordy slides, is when this starts getting into that area where we're a little bit uncomfortable with it, I think those are, number one, great cases to bring to our attention at the Echo. And we live and we thrive and we love your cases. So please bring those cases to us. And I think, letting the patient know that you're bringing that Echo case, or bringing that case to an Echo, a panel of experts, to see if they can think of things that you haven't. Again, it only improves the relationship with your patient. And then documenting that on the chart that you've discussed it. I would be shocked if DEA or Board of Medicine, Board of Pharmacy came down on you for one case. But if they did, you're clearly struggling with the case. You're clearly wanting to do the right thing for the patient, build a really compelling argument that you're going above and beyond. And applaud you for that too. So, patient buys in with a gradual taper. Also started using a TENS unit for his chronic pain and those muscle spasms, encouraging some physical therapies with a good response. He started patient on some duloxetine, titrated him up to 60 milligrams daily, and we're following him up in 2 weeks. So also reminding some self-care here. I think I'd like to speak for us on here, that we're in medicine to help people, that we enjoy that aspect of the job, learning on the academic side. And you wouldn't be here if you weren't trying to, I appreciate everybody taking time out of their busy life to be here to learn something, to take care of your patient better, but also making sure that we take care of ourselves. Taking care of some of these patients, just as Sarah kind of explained, can be really draining on us. And I think if it's draining on us, it's going to be even more draining on our patient, and to consider, hey, something might not be going well. Developing a committee, within your practice, within your hospital. It can be somewhat informal. Two of the hospitals that I practiced at before coming to New Mexico, we had a pain panel that involved the ER as well as the community, and discussed how best to seamlessly provide care for our patients. The one I was most active in involved a small community in rural Michigan, and basically having the ER on the same page as the primary care docs, we felt was important. And it gives you a chance to meet your colleagues. So yeah, with that, this is old slide, so y'all don't need your X waiver anymore for buprenorphine, but if you need help on that, like I said, the Poison Center is more than happy to guide you through. And with that, those are the end of my slides.